90% of the time it's coronal, but here we've got the sagittal, so the one straight up and down. The set tropism, again, that's the, somebody said it's turning, it needs turning. I don't know, I gave that person that said turning credit, but I don't know that I like the idea of turning. Tropism usually indicates that there's an asymmetry. So one side is one thing, the other is the other, whether it be coronal or sagittal. The fact that you've got two sagittals doesn't make it tropism. It has to be two different on one coronal on the right, the other one maybe sagittal on the left. And usually it's at L5, S1, but I've seen them at L4. I've never really seen it beyond L3. I've seen it as high as L3, the asymmetry. And it's an overcall diagnosis in that just because you have that doesn't mean that they're going to have all kinds of problems. But usually having it is a precursor to degenerative changes about those articulations. So here it is, sagittal, and here's coronal. This one is oriented like this, right? And this one straight up and down. Nuclear end plate impressions. Cupid's bow goes along with this. We don't want to mistake it with Schmorl's nose. So these are the nuclear impressions or invaginations. They usually occupy the posterior 2/3 of the inferior end plate. Here we've got one there, but again, usually the superior end plates are relatively flat. Here is impression, here's impression. So you can almost say that, oh yeah, the nucleus is right there. So, and everybody has these. So a few people have put nuclear impression. I mean, if I were to give you this slide, I think you would say nuclear impression because there's really no other normal variant. But some people have been giving you nuclear impression if, you know, there's something like the transitional lumbosacral segment, and they're not giving me the transitional lumbosacral segment. So I didn't give them the point because that's the biggie, not this. So it's all about what's clinically significant, and I would expect that you would agree with me that the transitional lumbosacral segment has more of an impact clinically than this. This means nothing for the most part. Okay, what it does mean though, and I may have mentioned this, that if it's not the posterior 2/3 of the end plate that's involved and it's more the middle to anterior, that might tell you that the person maybe have altered weight bearing or lordosis has changed or whatever, kyphosis, for an extended period of time. And so, you know, these impressions are all in response to gravity, right? So if they're in a location other than where they should be, the posterior 2/3, it might reflect long-standing loss of normal lordosis or kyphosis. Okay, and here is the Cupid's bow, right? This is the bow part, the arrow is there. And if you look at CT, this is what you might could see, is areas that aren't as radiodense because it's just not as thick when you think about it. This is a thicker area when you measure from top to bottom as compared to this area. So there is going to be a difference in the bone density where the impression is. Right? Okay, so here's a Schmorl's node. The difference is this occupies a fairly large area, not that the Schmorl's node couldn't either. But all you've got is a thin density there. Here you've got a fairly fuzzy, irregular density, and that's where Innate has tried to wall off the interloper, which is, again, the nucleus pulposus, angular fibers, maybe some end plate, osseous elements, and Charpy's fibers, etc. And usually it accompanies a decrease in the disc space. Whenever you migrate nuclear material, it'll result in a decrease in the disc height and the disc-over-tubular junction, and that more specifically you'll find up next trimester is called intervertebral osteochondrosis. So there's the difference here. This general impression, nice general impression versus irregular sclerotic work. Normal disc spaces, if you compare, this disc space will be decreased. Okay, ununited secondary growth centers, again, differentiate them from, and this was on your quiz. This is the ossicle Oppenheimer or unfused hypothesis associated with the inferior tubular process. There's no reason why it couldn't be the superior articular processes, but I've seen it mostly in the inferior articulations. Unfused spinous process. And again, the nice parallelism that exists between the two bones, and nice cortex on either side. Here, this is an unfused apophysis. This one, maybe because it's a little bit larger, we can refer to as maybe a lumbar rib, providing that this is, I can't tell, this might not be L1, this could be T12, right? And you get these differences. Or you can have agenesis of 12 thoracic ribs as well, right? This here, unless it's something on the cassette, is perhaps a gallstone, cholelithiasis. I'm not going to test you whether that's going to about that. This is just a close-up of the same. Okay, iliolumbar ligament calcification. I don't know what to tell you about that. I had mentioned before that it could indicate intersegmental instability, and that's why ectopic calcification has arrived there to fortify that ligament. I'm sure. Vertebral body size and shape. Remember, we said that the cervical vertebrae, the anterior and posterior heights are the same. We said the thoracic vertebrae, the posterior heights are 2 to 4 millimeters higher. That is also true of L1 and L2. Then L3, the anterior and posterior heights are like the cervical, so they're the same. But at L4 and L5, now the anterior height becomes 2 to 4 millimeters higher. And we need to know that when we're trying to determine if there is a compression deformity, just how much that compression deformity is. This is kind of interesting. I keep on, try looking at this slide. And I would like to say that this is disc lesion, but I don't know that I can. So be very careful, just because you see, I don't see enough evidence to make that disc lesion. But I could be full of below too. I mean, if I had MR, maybe I'm 100% wrong about that. But I keep on looking at that, and it looks fairly normal for the most part compared to the other side. Maybe there's a little tomorrow's or something in there, I don't know. But just because there's a decrease in the disc space, we see it at L5S1, we see it at CT3. It's just the way it is, So is that just the way it is? That this was almost a block mechanism? Block vertebra? I don't know. Okay, so transitional segments. We said that we're not going to use words like lumbarization, sacralization, or here's another one, pseudo-lumbarization. I've been known to use quasi. Who knows what quasi means, right? Anyhow, we just say a transitional lumbosacral segment, and you don't have to say L5 or S1, anything like that. And I think it's important to say with or without functional accessory articulations, right? And if there's just one articulation where the spatulated transverse is articulating with the ala of the sacrum, then you would indicate that the right sided, right? And you might want to indicate that the other side maybe is fused or not fused, right? And sometimes that's the way it is. So I think it's better to use descriptive terms like that rather than putting it into categories. And the reason for that is that the articulations, they are truly synovial joints, but they're cheap grade, right? So they undergo degeneration fairly rapidly. So, we need to know of their existence so that the next person may be providing to a patient with a little travel card, and you said that the patient had a transitional lumbosacral segment, that maybe as they're vacationing in Colorado, the chiropractor that they go to there would say, oh yeah, I can figure that one out, right? Okay, so anyhow, sometimes transitional lumbosacral segments are called just that, even if the transverse process is just spatulated and it's not articulating or even close to the ala of the sacrum. So realize that probably, if you're going to think about degrees, would be the earliest of degrees that will be significant. Okay, so here we've got a transverse process here and a transverse process there. Right? They're kind of a little spatulated, but is there a little articulation there? Could be. Right? Do we have tropism here? I think we do at L4-5. There's a sagittal there. There's a coronal there. They kind of look rounded. Right? I don't know what to tell you about this articulation. You can't see it well, but I see a sagittal there. So it's not unusual that with transitionals you have other things, right? Just like it's not unusual if you've got something in the cervical region to have something in the lumbars. But oftentimes we'll see multiple issues, yeah.
So for that one, would you want us to say that that's transitional, almost sacral, or spatulated transverse vista? For that one, would you want us to say that that's?
I'm not
Oh, okay. Don't worry about it.
That's mad. That's very spooky. It's just very good. All right.
Surely I can find a better one. Okay, so, I do call them accessory articulations. Now, this is a nice one. Can I have this one on? Can I put this one on? Maybe. Yeah. So here you've got somewhat of a normal, not really though, it's spatulated, it's larger. I mean, just compared to the ones above, you'll see that this has more height to it. Here we do not have an articulation, but this is quite characteristic. Whether you do or don't have an articulation, the relationship between that spatulated and that ala oftentimes results in the formation of a brain like that. So, and the same thing here. This one, however, does have an articulation, doesn't it? And it might be undergoing a little regeneration. I see a little hypertrophy there, and I'm seeing a little bit of sclerosis there. And even this transverse process doesn't look like the others. It's kind of nubby. I mean, normally they're maybe a little broader anyhow, but this one probably is a wannabe like this one. Never happened, never will happen. The knife clasp or the clasp knife deformity, right? Again, we're not going to call it a syndrome unless the patient does extend, and this is so long that it jabs into, the area where the caudate point is. Agenesis, hypogenesis, I guess that's always possible. Here, right, we're missing what? We're missing one of these. What are these?
Pedicles.
Pedicles, right? And you can see that this pedicle here is extremely large, and it's working, and it's hypertrophy. It's working for both pedicles because this one's missing. So, again, we talk about, and you will, in 6th, 7th trimester, the winking owl sign or the one-eyed pedicle sign. That means that there's probably mets, right? Or maybe there's a multiple myeloma or something like that. However, the chances are that that is probably foaming enough or aggressive enough that there's not going to be enough time for that pedicle to get large, right, and sclerotic. So when the pedicle gets large and sclerotic on the opposite side of the missing pedicle, then that's telling it's probably agenesis. But Yoakum talks about this, and you need to know that the most common cause for a sclerotic pedicle is what? Probably unilateral spondylolysis. Remember how I said that if you've got spondylolysis on one side, the spinous process will rotate to the side of the lysis, and the contralateral pedicle will get very sclerotic. So Yoakum says that that's the #1 cause for a sclerotic pedicle. Not that it couldn't be degenerative change, not that it couldn't be something like this, but usually, more commonly, it's the other. It's unilateral spondylolysis. Okay, block vertebrae, you know all about those. Again, the wasp waist and blah, 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 blah. So here's the wasp waist. Normally on the lateral, we see our IVF, so in the cervical spine, we would see an IVF, which you wouldn't normally see on a lateral. But the wasp waist is real. The heights of the vertebral bodies don't seem to be quite the same. The rudimentary or vestigial disc, this one isn't so apparent. It's like it's all huge. Hemivertebrae, usually it's the lateral aspect, not that it couldn't be the anterior aspect of the vertebral body or the posterior aspect or some other elements. So, but this is the most common. And this is maybe where some people are getting confused. The butterfly vertebra is kind of a variation of the hemi, but it's not the same thing. And so this is where you've got nuclear material in the disc here, nuclear material in the disc here, and there's a connection between those two centers of nuclear material. And that connection is through the vertebral body, right? So that separated out the vertebral body into respective right and left halves, but all the posterior elements are still the same, right? So, but a hemivertebrate isn't like that. A hemivertebrate, a whole portion is missing, right? Here, it's like just a central core, and so if anything, it's a substitute scheme, right? So osteoid has been substituted for notochordal material, that's all. But with hemivertebra, a portion just didn't develop, right? There's a little bit of a difference there. So, anyhow, so the butterfly vertebra, this is the vertebral body here, but you're looking through the posterior elements. So all of these elements are here as well, but it's just the vertebral body that is compromised with, again, nuclear material connecting to disc spaces. And then, of course, here you've got spina bifida. Here, you've got a transitional lumbosacral segment with bilateral functional accessory articulations. Okay, SI joints. So, we know that in young people, SI joints can be very wide, right? So, until they become a young adult. So, actually, it starts changing probably around the same time that the spine has stopped growing. So, when they're like 17 or so, they assume somewhat of a normal size. This one here looks a little sclerotic. Now that could be stress-related reactive sclerosis, whether it be, the patient that has the scoliosis, the lady that's had a baby or a number of babies, right? I mean, those are all possibilities. What you don't want it to be is like an inflammatory arthropathy, like ankylosing spondylitis, right? Because those are the early signs, is the widening of the SI joint, especially the anterior SI joint, and the sclerosis on the ilium side. Why do we get sclerosis on the ilium side? Because the articular surface, right, the cartilage, the hyaline cartilage is thinner. Right? So it breaks down easier, or is worn through. So fairly wide SI joints. In the female, you get what Dr. Thompson will call osteitis. Don't write this down. This is not on the test. Osteitis tenatus iliac. The sacroiliac, you know where that is. But on the lateral, right, it's this area here that's adding density. And these, I don't know that you need to know what those are. Why don't you write it down? Iliopectineal lines. And all that is the rim of the pelvis. So iliopectineal lines, and after that, of course, is the sacroiliac. Iliopectineal lines. I tell you why. The reason I'm saying that is that students are always asking me what that is. They think it's stress fracture or something. I'm not sure. But that's just the brim of the pelvis. That's just this area. Right. Actually, it's got to be higher because it's overlying. The first sacral segment, a little bit of the body. So it's just the pelvic brim, basically. Okay, bowel gas. Let's not worry about that because we've got a whole presentation coming up on too much, not enough gas. It's spinous processes, right? Vary in shape and size. They're horizontal. This one might be a little larger than the others. If it is, you want to be suspicious that maybe they've got some mass in there. Right? Could it be a chordoma? Maybe. Could it be an osteoblastoma? Maybe. Could it be fibrous dysplasia? Maybe. So you just don't know. But they're horizontally, and then this one is peeking off to the side here, the patient's right side. So they can take on different flavors. When they get a little too close, then we say they've got hissing spinuses, right? It's also, don't worry about that, you do that, it's right, Bastrup's disease. And usually then they become sclerotic where they kind of butt up against each other, and they become even bigger and squarer than otherwise. The IVFs, remember, this IVF here at L5S1 may not look as big as the other IVFs, and why is that? Because I think that was that on the test? I think you had that as a first question, I'm not sure. I'll have to go back and check. But it's because they're angled, because we know that the anterior sacral foramen are on an angle, so you're in an area of transition. So the central ray is not as aligned with these IPFs as it is with the others. Okay, so rotation and lateral flexion, we've talked about that before. The fact that you can see the undersides and top sides of vertebral bodies tell us that that's what's going on. Here, rotation will give you a pseudo-retro appearance if you're picking up the wrong cortical margin, all right? So, and it's also true that we know that the inferior end plate of the L5, for example, needs to measure the same as the sacrum, just like all these other end plates have to measure the same. Otherwise, you've got pseudo-retro. But we can tell if there's rotation here. Here's one cortical margin on one side, one on the other. Not a lot of rotation here. So you can see conceivably, if I pick up this cortical margin, and then I've got to come forward to pick up this one, I would think that this is retro. But here is the same cortical margin right there of the two vertebrae. And you can see there's some lateral bending, right? Because here's the top of the IVF on one side, the top on the other side. So there's not just rotation, there's rotation and lateral bending, which makes sense if you've got scoliosis. Usually the apical vertebra is rotated the most in that curvature. So here again is a lateral flexion. Okay, so that does that. There. So that was the biggie. But we need to look at and then let's do scoliosis and spondy. That'll be a little clever, I think. Okay, all of these different classifications or whatever, I don't know, the nomenclature we kind of need to know. The apical vertebrae, you know that that's going to be the one that is in the center of the curvature, right? That's easy enough. Compensatory curves, you know you've got primaries and secondaries. So sometimes it's hard to determine what came first, like chicken or egg, right? I have no idea sometimes. But, you know, obviously if they've got hip dysplasia, if they've got a pes planus, if they've got a knee issue, right? Then what's significant there is that's the etiology. And so until that's addressed, you know, you're going to have these curvatures, whether they're primary or compensatory. What's important is to see whether or not, say in the case of the lumbar spine, compensation has occurred, where the pelvis is level, or that the shoulders are level, right? Or at the occiput, when you know, look at your AP, that the little angles of the jaw here are level, right? That's what's important, that kind of compensation, not the fact that one curve has been responsible for the other. Functional curve, you should know, that's when you do the Adams test, right? And they bend over, that it straightens out, right? But if it's structural, then it doesn't, right? So we obviously will do better in chiropractic when we treat our patients if they have a functional scoliosis. And realize there are different types. You can say it's iatrogenic. So the patient that maybe had, you know, lumbar fusion might end up with a scoliosis, right? Definitely will end up with hypermobility and degenerative changes above where they did the arthrodesis or the fusion. But you can have pathological because of a tumor, or you could have traumatic, right? I mean, there's all kinds of possibilities. And definitely congenital. Most of what we see in North America here is idiopathic. You see more in females. It's right-sided, right? You need to know that, right-sided. And we're talking about adolescents. We're not talking about juvenile. We're talking about adolescent. Right-sided thoracic convexity, right, is the most common and treatable chiropractic. The gibbous, that's an acute angulation. We see that in patients that have TB, tuberculosis of the spine. So just realize that usually it's associated with pathological, right? And we're talking about, you know, that being like the kind of apical area or where the vertebra, apical vertebra is. But to talk about major and minor curves, I don't know if it's even worth it. Okay, so idiopathic represents, at least in North America, not in Central America, not in some South American countries, especially, you know, where people are indigenous, right? They can have congenital. for sure. But anyhow, idiopathic resolving. And it's, this one here that I want you to know, right, is 85% of all idiopathics are adolescent in their onset. I mean, little kids go in and out of scoliosis all the time. So usually it's right side convex. Okay, so let's use this one as an example. They would have, to determine that 84 degrees, used what line of mensuration? Called the COB, C-O-B-B. So that's the gold standard. You always pick the vertebra at the top of the curve that's going to give you the greatest amount of, measure. And then you draw a line along its superior end plane. Then the inferomost vertebra that is going to give you the greatest curve, draw a line along its inferior, though not superior, inferior end plane. And then what you do is you drop your perpendiculars, and it's going to be a small angle that you measure, just like it was for lordosis. So this is important, Reisers, right? The Reiser sign. What we do is we divide into quarters, just like we did with the Meriding, but we're doing the crest of the ilium now, right? And a phi would be when that apophysis has fused, and then we know that the spine has stopped growing. But anyhow, when it moves from a 1 to a 4, 1 to 2 to 4, the chances are the spine has stopped growing. So it starts here as a little coalescence. You can see that there's a little bit of a residual area there. And this is a 17-year-old. And by the time they're 21, that little radiolucency you can see here and here will go away. But as long as it's gone all the way from here, a coalescence of osteoid to here, then it's a 4, and the spine should stop growing. So, there we go. Okay, so Reisers, 16 or so, and the female, male fall a little bit behind, more 17. If I'm passing it, then it's not important, right? I'm not talking about it. Just know the cause, and this is it here. We just talked about it a little while ago. I guess maybe we should know this, at 20 to 30 degrees, we're just going to monitor the curve. But I tell you what, if it's an adult, you're not going to get excited, right? If it's a child, yes, you will. If it's prepubescent, if it's an adolescent, you still get excited. But if they're out of adolescence, then no big deal. It's really not going to progress that much more. Where we worry the most is during that informative period, that growth period, right? So from childhood to adolescence. That's where you really have to monitor it. But after the spine has stopped growing, I mean, it'll probably grow some or increase some, but it's not going to be accelerated. So we have to be worried about it. A lot of this is interesting, but not for this class. Okay, so spondylolysis means that there's a cleft. Spondylolisthesis just means that there's slippage of the spine. It can be anterior, lateral, posterior, whatever. So know the terminology. I'm not worried. I'm not going to test over the incidences. The clinical finding, now there can be pain just because you see that they have bilateral spondylolytic spondylolisthesis, whether it be grade 1 through 4, may or may not be with any clinical presentation, just like herniated disc. Just because you see it, and definitely bulging disc, doesn't mean that there's going to be clinical presentation. I mean, everybody in the room today has a bulging disc, right? That doesn't mean that you're going to be debilitated as a consequence of it. And when you go home tonight, and rest, you rehydrate, right? And you're not bulging as much. Towards the end of the day, you start bulging. Some of us are bulging more than others in different places, not even having anything to do with this. Okay, so, a lot of the stuff, you know, I don't get into all the different, you know, types and having categorized them like this. You know, traumatic and degenerative and pathological and iatrogenic and blah, 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 is more important than type 4, type 5, whatever. Okay, so we already did the Meridine, we're not going back there again. And you can actually see the George's line, that's another thing we need to remember. George's line is disrupted, obviously, with anterals or retros as well. And then, of course, our pars. You know, sometimes it's really hard, and that's true in this case, to see the defect. But sometimes, look at how nice and thick the neck is there, and how skinny mini it is there. There's a tuck into there. So sometimes it's not readily apparent. And on the AP, you would have expected to see radiolucency here. Might could be right there that we're seeing it. And here I can kind of hallucinate it, perhaps. Here I can see my pars defect through here. But and then here's a lucency here. And it's not at the pars though. This is more in the lamina, right? The body of our study dog. So that's what's going on with that one. Here, I don't think any problem. You can see that the vertebral body becomes very trapezoid. And I think I told you, but you don't need to remember this. This is called thoracic also, where the superior portion of S1 or the end plate sacral base becomes convex, and then the inferior aspect of 5 becomes concave. Did you have a question?
I still don't know what the Napoleon head sign is. The Napoleon head.
No what?
What the Napoleon head sign is?
Oh, that's where the transverse processes are overlying the ala of the sacrum, only because of the slippage of the vertebra forward. Yeah, so, joint arms, cat, bridge, sign, and full line of rail split are all the same. But it's just because, see, the transverse processes are here, and so they're going to overlie the ala of the sacrum. Let's see if I've got something to show you. Not so good here. But here's the transverse process. Eventually, with the slippage forward, the transverses will overlap the ala of the sacrum.
Okay.
Okay, so these will start overlapping with the ala here. The more it slips forward, that's all.
Thank you.
And then this is degenerative. There's all kinds of hypertrophic changes that are going around these articulations, both sides. And L4 usually, L4 is the most common, so you need to know that. L4 is the most common for degenerative. L5 is the most common for spondylolytic spondylolisthesis. So you can hypertrophy off the articulations. Sometimes they'll hook back into the articulation of the vertebra that's looking forward, the vertebra below. The supraarticular process will hook into that to try and stabilize it. Just like with L5, sometimes you can get buttressing calcium here, it's called, right? To try and hold that vertebra back, right? But you can see the degenerative changes, and you can see how they're, you know, extending laterally here, and that would be referred to as degenerative. Now, the thing is, again, this is not going to go more, in the lifetime of that individual, more than a grade 1, right? So usually they don't go beyond 25% of the distance along the superior plate of the vertebra below. Okay, so here we've got a cleft in the posterior arch. See that? And then look at this pedicle, right? So here's the site of spondylolysis. This is what Jochen was talking about, that it's the most common cause for an enlarged and sclerotic pedicle on the contralateral side, the side opposite. pars defect. But here it's not so much the pars, this is just lemma, makes no difference. So here you can see defective through here. And then this is the sclerotic catacomb. The defect is here, it just continues on, you just can't see it so well. Okay, so, good to meet.